Oh, and if you're talking, I can't hear you, but maybe that's on my end.
I wasn't able to hear him either, Robin.
All right, I'm just checking my audio. Can you hear me?
Yes, we can hear you.
All right, sorry about that. Mr. Bent, do you have everybody with you that you need?
I think so.
Okay. And Maggie, are you all set to go back on the record?
Good afternoon. Yes, I am.
Great. We'll resume the Care Board's hearing of August 12th. And next we have Gifford's presentation of its budget. Our last presenter, Ms. Sweetnam, was her first Care Board hearing. And if my memory serves, I believe it's Mr. Bennett's last. Well, yes. Mr. Bennett, thanks for your service to the state. And I welcome you to your last Care Board budget hearing. I'll turn it over to you.
Thank you, Chair Foster.
Chair Foster, just to note that we need oath to be administered to witnesses.
All right. Would you mind doing that?
Yeah, happy to. Just see, Mr. Bennett, who all is going to be providing testimony today?
We have our interim chief financial officer, Bill King, our controller, Steve Conti, our chief medical officer, Dr. Josh White, our vice president of nursing, Jill Markowski, and our vice president of operations, Rebecca O'Berry.
Okay, so let's do it this way. I'm gonna read the oath, and I'll ask that after I read it, each person who plans on providing testimony simply state your name for the record and say that I do, or that you agree. So we'll do it that way. That way we have everybody's names on the record. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
Dan Bennett, I do.
Bill King. Bill King, I do.
Josh White, I do.
Jill Markowski, I do.
Rebecca O'Berry, I do.
Stephen Conti, I do.
That was everyone.
Thanks very much. You're all sworn in, and it sounds like I can just turn it to you, Mr. Bennett.
All right, thank you very much. And Steve is going to share our slides. So Steve, if you would please bring them up. Okay. You can go to the first slide, Steve. Okay, well, thank you very much for the opportunity today to discuss Gifford Medical Center and our fiscal year 2025 budget. I just noted the colleagues of mine who are going to be joining me today, and we look forward to having this conversation with the Green Mountain Care Board. I want to start first today by noting Gifford's unique and innovative governance structure. As you'll see on the screen, Gifford is one of only a few organizations in the country, and there's either one or two other organizations that have the same structure we do, where a federally qualified health center, or FQHC, is the parent organization for a hospital. In our case, there's a second subsidiary corporation as well, Gifford Retirement Community. FQHCs are regulated on the federal level by HRSA, and like with hospitals, that regulatory environment can be complicated. One of the key regulatory principles for FQHCs is that they cannot be owned or controlled by another organization, such as a hospital. And therefore, our structure reflects that requirement, with the FQHC being the parent organization. Of note, that also is consistent with the way that Gifford has operated as a primary care-driven organization. Gifford Medical Center, although a subsidiary of the FQHC, is the largest component of our organization in terms of revenue, expenses, and the number of employees. And the budget and other financial information we're presenting today to the board is solely for the hospital, Gifford Medical Center. That being said, there are times in the presentation today where we will talk about primary care and affiliated services, and we will do our best to note where we're talking about the FQHC. Next slide, please, Steve. So just to further illustrate, I want to note services that are within the hospital and services within the FQHC. And first, on the hospital side, we are, as you know, a 25-bed critical access hospital. And contained within those 25 beds are our medical surgical unit, our swing beds, and our birthing center. Our surgical and specialty care practices are located within the hospital structure. And you'll see examples on the slide of those services that we provide at Gifford. I have noted on the slide with an asterisk 2 services in which we collaborate with other hospitals. We collaborate with Dartmouth-Hitchcock Medical Center and Orthopedics for joint replacement to supplement our in-house general orthopedics. And we also collaborate with the UVM Health Network on oncology services. And these collaborations allow us to offer these services safely to our patients in their local community. In addition, all of our ancillary service, our emergency department, our surgical services, and our rehab services fall within the hospital structure. Next slide. Our FQHC, we operate throughout central Vermont from 5 sites, and this encompasses all of our primary care services, family and internal medicine, pediatrics, our psychiatry and counseling, and all of our other services that we provide here. The FQHC model does allow for better integration of all these services within a primary care structure. And within our structure as well, we're able to integrate better within the hospital side of things also. So it's it is a good structure for us to be able to share those services. Next slide, please. So the current state with Gifford, this 2024 has been a recovery year for Gifford. We had a good many things going on. Our team has been engaged in implementing a new electronic health record, and also along with that, improvements to our revenue cycle operations. We've continued to identify cost savings throughout our organization, and we also continue to engage in numerous workforce development programs. All of these efforts are in support of our work to improve affordability, to meet our community need, and to create a sustainable plan for Gifford's future. Next slide. There are a number of risks inherent in our current environment. And the Gifford team is working diligently on many of the topics that I'm going to cover in the next 2 slides. Some of the challenges and the opportunities that we face are within our control, while others are not. We initially had planned for our electronic health record implementation to go live in July 2023, so that would have fallen in the previous fiscal year. But we ultimately made the decision to move that into October 2023 to ensure a better experience with our go live. So that moved it into the current fiscal year 2024. We are progressing well with this implementation, but as is expected, we will continue to make improvements going on with the system, both in terms of stabilizing the system and optimizing the system. We've enacted a financial improvement plan that is achieving results, but we need to ensure that we can recognize a bottom line that's adequate for us to make necessary investments in order for us to keep our population health programs that impact affordability, and also to make reinvestments in Gifford's plant and equipment. There are statewide challenges that are beyond our control, and they continue to hamper our efforts. I don't think it'd be news to anybody that Vermont does not have enough working age people to fill our jobs, whether that's in healthcare or otherwise. We also lack housing, and these create a barrier for us to be able to retain and recruit a qualified workforce. So in addition to our efforts here at Gifford, there needs to be these issues need to be addressed on a statewide basis, or they'll continue to impact access, affordability, and the sustainability of our healthcare system. Next slide. There are many positive things going on at Gifford. We've made critical investments in population health, and these investments directly impact our ability to provide the right services in the right setting, and this positively impacts affordability. We're leveraging our new systems and the data they provide us to inform decision-making throughout our organization, something that is long overdue. And Gifford continues to cultivate strong relationships with our local, regional, and statewide partners to meet the needs that exist here in our community. Next slide. Gifford is governed by a volunteer board, and one of their ongoing duties is to create a strategic plan that they do every 3 years to guide the work that we do here at Gifford. Our current strategic plan expires at the end of this calendar year, and that plan has emphasized our people, population health, investments in our infrastructure, and also our governance. Our board will conduct a new strategic planning process in 2025, calendar year 2025, in which they will incorporate data from many sources, and these will include our 2024 Community Health Needs Assessment, our Employee Engagement Survey, which is going on now, our community listening tours, Act 167, and many other sources. Next slide. As a community-based and community-governed entity, our Gifford team seeks input from those we serve. Over the past 2 years, we have conducted listening tours in several of our communities. Themes that we heard in our first year, which was in 2022, included access to mental health services, transportation, food, and housing as issues. Based on those conversations, we invited 3 of our local partner organizations who focus on these areas to join us last fall in 2023 to speak about their services and resources, and also to hear additional feedback from the communities. And the themes that we heard last fall were consistent with what with those that were in our 2024 Community Health Needs Assessment. Again, access to transportation, housing, medical, mental health, and dental care. And as I noted on the previous slide, we will utilize this information in our strategic planning process going forward. Next slide. I noted earlier that we have a financial improvement plan, and we have implemented many cost containment efforts here at Gifford. Some of those are highlighted on this slide, and they include adjusting some of our staffing models in order to align with patient utilization. We've been able to do this in our medical surgical area and with our hospitalist, and also with our respiratory therapy department. We've been able to combine some management positions, and this has been something we've been able to use our position control process to help with, where we're able to evaluate positions when they come open and have discussions with people in those areas to determine whether there's a more efficient way for us to meet the obligations of those positions. And we've been able to do that this year. We also took a big step this year in that we outsourced portions of our revenue cycle functions, our billing and our coding. And from that, we've been able to drive improvements both in terms of our collections from commercial and government insurance programs, while also having some cost savings. And Gifford has long worked with our partners at Efficiency Vermont to be a leader in seeking energy efficiency. And this is something that we'll continue to do over time. We've seen benefits in this work, both in terms of having funding available to help us as we engage in projects, but also in recognizing operational cost on an annual basis. And we have saved a significant amount of money since through those efforts since 2017. So these are things we've been working on this year, and these are items that Gifford will continue to work on going forward. We'll continually seek out areas where we can drive efficiencies and cost savings. I'm going to now turn it over to Jill Markowski to talk about some of our workforce initiatives. Jill?
Hey, good afternoon. As Dan said, I'm Dr. Jill Markowski. I'm the VP of Nursing here at Gifford. Been proud to be with this team for the past 2.5 years. And my primary focus really has been trying to help stabilize the nursing workforce. To kind of back up a little bit, pre-COVID, Gifford had the comfort of really having a locally sourced, long tenured nursing workforce. Some could say that we had lifers. They came to work at Gifford and have stayed here. But post-COVID, we've had many retirements, some nurses kind of aging out of the workforce. And unfortunately, there's no workforce or pool or bench to readily replace those folks. And the same issues that Dan talked about a little bit earlier in the state of Vermont kind of affect the Randolph area as well. So that shrinking workforce of that young demographic, limited housing options, and not as many opportunities for our young nurses, meaning they kind of don't stay here in Vermont. So like many places, we had to resort to using travelers. And as we know, that transient workforce that's kind of paid 4 times what our normal staff are and are not really committed to the organization or the community is not who we want caring for our patients. So we really had to play a bit of catch up at Gifford to kind of meet our peer offerings for recruitment and retention and figure out really innovative ways and creative ways, giving our limited resources to recruit new folks. We had to highlight that all the positives that we had here at Gifford is a great place to work and a great place to receive care. Some of the things that we have done, we've really increased our wages substantially to remain market competitive. Of course, that's an ever-moving target. We've increased our benefits. We've increased our tuition reimbursement and in the amount and the coverage. We're working on creating our clinical advancement program. We reset all staff schedules and staffing patterns to be aligned with patient needs, not just to Dan's point earlier about having some efficiency and cost savings, but also making sure that the schedules were fair, equitable, and provided nurses really desirable stretches of times off and repeatable patterns. So all weekends off or at least 3 days. We have proud to say that our nurse-patient ratios really support best practice and quality care. We make sure that we align our patient needs with nurse competency. And we've spent a ton of time focusing on our onboarding. We wanted to create that environment that's supportive and results in successful onboarding that helps transitions those new nurses, some of them having been educated during COVID times, into practice. We revised and streamlined our general nursing orientation. We adopted a methodology for our new hires and our residency program that is competency-based. We focused on those preceptors, those folks that we're going to be teaching our new hires, gave them education, skills, preceptor training, additional differentials if they're having a student with them or a new hire, and created weekly meetings with the new hire, the educator, the preceptor, and the leader. It was really successful in that we could really easily identify any issues, and we were agile enough to adjust quickly. Proud to say we also have partnered with Dartmouth-Hitchcock and have a way in which we do our AORN Periop 101 program where they're able to go over to Dartmouth and have that clinical experience. So they're able to see a large number of the same cases in a way where they can start to understand patterns and consistency and start to look at those efficiencies as well. We also then started to recognize the folks that we had from a retention standpoint. We rolled out formal recognition programs here, the DAISY program for nursing. Proud to say we've had over 120 nominations, 4 great celebrations, and we have another one coming up next week. But despite all that, we still needed to kind of grow our own. We were really excited to be part of the Vermont Business Roundtable and the Vermont Talent Pipeline Phase 2 project. Unfortunately, that funding was lost. So we had to pivot and reset, and we have done that. We've developed our own program because we don't have that external workforce pool. And we did have a lot of folks who really dreamed of becoming a nurse, but couldn't financially afford to do so. So we partnered with VSAC, CCV, VTSU, and I'm really proud to say that this fall we have our first cohort of 6 folks going in with their prereqs, 3 others in the actual nursing years, and then we're also investing in 6 nurse leaders to get their MSN, because there's also a nursing faculty shortage here in our schools of nursing. And there's not enough faculty to prepare our students. But this really goes beyond just giving them the finance. We've also been giving them the emotional support, encouragement, and coaching, and investing in them so that they're successful. This fall, we are expanding this to try to partner with our local high schools and increase the awareness of opportunities at Gifford Healthcare, job shadows, internships, and then also working to create some formal educational support pathways for students that maybe thought that they couldn't possibly go into radiology or nursing. We also have had a successful MA program. We hold that program twice a year. Those MA students usually come from within and then join our workforce. LNA program, we've also partnered with some outside agencies, and we're actually investigating doing our own. One of the biggest investments that we've done is we created a joint affiliation position. This is a shared position that Gifford Medical Center has. There's some other hospitals in Vermont that also use this model, but we pay the salary for a Gifford MSN prepared nurse educator, and then she works as VTSU clinical faculty and manages those rotations for the Randolph cohort. So it's going to Meneg, going to Woodbridge, going to the Sim Lab, going to any of our sites here at Gifford Healthcare. VTSU does reimburse us the faculty pay portion, but that does not come close to covering the salary, as we pay the salary and the benefits for this educator to really work as VTSU clinical faculty full-time. Now, some might say this view is an additional salary expense, but we see really beyond that. We view this as an investment in our future nurses at Gifford and in the state of Vermont, and to help stabilize those VTSU nursing programs. With all that said and all that focus here locally, we still didn't have enough folks and needed to look beyond our regular local workforce. I'm proud to say that I was the first to partner with a company called InSpring, where there's foreign trained nurses that you work to help them convert their student visa into a work visa. And we hired an amazing nurse, Ana Gonzalez. She's originally from Colombia, was trained down in Texas and Louisiana. She joined us this March. She went to Dartmouth for the Peri-Op 101 program, and she's successfully working in our OR. She's been a great addition, and we have 2 other nurses that will be joining us this fall, one from Nigeria and one from India. So with all that said, here's some of our results. That joint affiliation nurse educator position resulted in our nurse Nina supporting the entire clinical rotations for over 105 students last academic year. We've onboarded new nurses into an environment where they can really safely transition into practice, and we have an 87% graduate nurse retention rate. I'm going to say that one more time because that one makes me happy. 87% graduate nurse retention rate. We also have converted some travelers into our permanent staff. They kind of have come here as travelers. They like the culture, they like the environment, and they signed on. So we've been happy to say we've reduced our traveler usage by 67%. Still struggling in a couple specialty areas like the OR, but I am confident that by February of 2025, I should not have any OR nurse travelers. And while we still have challenges as a critical access hospital, we continue to have our culture and our commitment to our mission remain our guiding framework. I'm pleased to say we're able to evolve and adapt, and we're always kind of recognizing and valuing our best asset, which is our staff. It's been really a great a time for us to kind of rethink how we do things and to do things in a little bit different way, and we've been very successful with that. So yeah, thank you for letting me share some of the successes we've accomplished. I'll gladly answer questions at the presentation end. And I think Dr. Josh White, our CMO and a strong member of our ED provider team, is up next.
Thank you, Jill. My name is Josh White. I am an emergency physician and have served as chief medical officer here at Gifford for a number of years. It's my opportunity to introduce a project we call the Value Committee. Here at Gifford, we have long believed in the transition away from fee-for-service care into outcome-based care and quality-based care, ultimately to achieve the goals that our patients have, rather than the drivers of finance. Subsequent to that, about a year and a half ago, we established what is called the Value Committee with an attempt to marry the cost of care with the outcomes that we want for our patients. I'm going to talk about two projects that we've embarked upon and continue with. First one regards high-end radiological testing, specifically CT scans and MRIs. We looked at CT scan utilization and MRI utilization in primary care and CT scan utilization in the emergency department. This is a focus of a number of quality groups with a recognition that there are a significant volume of tests being performed that patients don't really need and that don't improve the outcomes of care. Obviously, these things aren't free, and the community and the patients foot these bills. We asked ourselves what we could do, so we started with a data collection period during fiscal year 2022. And then in 2023, embarked upon an educational process for the staff. There was no carrot, no stick. It was our presumption that upon being shown the data, providers would largely fix this themselves in recognition that these are highly intelligent, highly driven people, and they don't want to be outliers. After 6 months of educational intervention, we did CMEs, we did talks at the division meetings. We brought in presenters and sent out information. Ultimately, in primary care, we generated a 15.3% reduction in utilization of CTs and 11% reduction in MRIs. In the emergency department, we saw a 6.4% reduction. What that bears out to annualized is we're predicting that we eliminated in primary care about 163 CTs that didn't get performed that otherwise would have, and 82 MRIs, and 156 CTs in the emergency department. The savings here comes out to around $400,000 estimated. Obviously, we're trying to predict the future, so I can't say that specifically. But aside from that, this includes a reduction in utilization, freeing up space for other patients. It frees up patient time that otherwise would have been spent, contrast dye injury, and injury from the radiation that the patients would have received. This is a project that we're going to have to periodically repeat. Old practice habits die hard, and we have new hires, so it's our intent to continue this periodically. Second project I'd like to talk about was a high emergency department utilizer project. This is in recognition that if a patient is repeatedly visiting the emergency department, somewhere in there is a failure in care. If you have to come to the ER again and again, you're not getting what you need. In looking at the research on this, essentially each individual patient has a reason where they don't mesh with the medical system as designed. Something about them, it just doesn't work and they're not getting what they need. In response to that, we developed a multidisciplinary committee for each and every patient on our list. And we brought in every healthcare personnel that touched the patient, be they Gifford employees or not. We include the designated agencies, the local EMS agencies, everybody that would know something about that patient. In those multidisciplinary groups, we shared information who knew what about this person, who had some insight as to why care was failing. And then we had conversations about how could we redesign our approach to this person to better meet their needs. We did our data analysis for this one beginning in January of 23. Each patient was individualized, so it started at different times for different people. And then our intervention were the plans that came out of those individualized meetings. Ultimately, we selected 18 patients and observed a 33% reduction in ED utilization amongst those patients. This was extrapolated of those 18 patients to a little under 87 visits per year predicted saved, and a cost savings of about $131,000, over $7,000 per patient. This is something that we also intend to continue. We feel it's a significant benefit to patients. No one wants to be in the ER as a general rule if you don't have to be. Everyone would prefer to have their needs addressed and not go round and round in this cycle. So thus far, we're estimating an annualized savings coming out of the value committee of around $542,000. And I'd like to point out that that is not savings that Gifford is observing. This is $542,000 that is not being billed to patients. Although financially, that's a difficult thing for us to swallow. Ultimately, we believe that's the way healthcare is going, and it's our attempt to start to straddle that line. So I'll wrap up my part of the presentation, and as Jill said, we'll answer questions at the end, and I will pass the mic to Rebecca O'Berry.
Thank you. Good afternoon. I'm Rebecca O'Berry. I'm the Vice President of Operations here at Gifford. I'm here to talk about health equity. We are committed to continuing our work in health equity and reducing disparities across the continuum of care and through our communities. We are identifying and addressing these disparities through work that our DEI committee is doing. This team is focused on ensuring that Gifford continues to be a welcoming environment for our staff and for our patients and visitors. This team started with educating our workforce and promoting awareness around DEI. We recently completed our community health needs assessment, as we've already talked about, and the information gleaned from that survey is going to help drive the work that our population health team and our DEI teams are doing. This will help us create a framework from which to do our work. We are focusing efforts on optimizing our new EMR, which we also talked about a little bit earlier. This EMR has a way of funneling information from our patients on their social determinants of health into registries. And those registries can then be analyzed and pulled by our population health team. And then the work for outreach to our patients is performed by our community health team. These elements of SUH are helping us identify barriers and other ways that we need to improve across our communities with our community partners in reducing those disparities and getting people in and accessing care that they need. Our upcoming strategic planning process will also include specific efforts for populations experiencing health disparities or who are at greater risk. We're going to utilize both the community health needs assessment data and the data from our registries to help formulate that strategic planning process. Currently, we're in the process of partnering with an outside organization to host lunch and learn virtual platforms to further educate and openly discuss disparities and how to help for our entire Gifford community. Some of the ongoing initiatives we have are promoting gender affirming care in our provider biographies online, the creation and maintenance of a Gifford DEI webpage highlighting activities and awareness, and encouraging the use of appropriate pronouns and names within our organization. I am going to take questions, as others have said, at the end of the presentation, and we'll turn over the mic to Bill.
Hello, everyone. My name is Bill King. I'm the interim chief financial officer here at Gifford Medical Center. And I'm here to talk about some components of our budget request this year. First off, we're requesting a 6.8% commercial rate increase, which equates to $2,272,000. And our plans to use that money is to cover our inflation, which we have on a weighted average basis, 2.8%, and also to partially cover some of the capital spending that we would like to have accomplished. Next slide, Steve. Next element of our budget is that our net patient service revenue budget to budget year over year is going to increase by 8.2%. Elements of that increase are, as I mentioned on the previous slide, the rate request. At Gifford Medical Center, we are going to budget a reduction in our fixed prospective payment due to expiration of Medicaid COVID era expansion. We are also budgeting on a budget to budget basis a decrease in utilization. But as you've heard throughout the presentation, we'll be leveraging our new EMR and our partner outsourcing partners with our budgeted billing and coding to see extra income there. One thing that is a decrease to net patient service revenue is our budget for fees and discount. But just as in other areas of Gifford's community, we feel it's the right thing to do, leaning into providing free and discounted care to our patients. Next slide. After it was all said and done with all the discounts from all the work that all the team has been doing to maintain expenses at their lowest level, our margin budget is 4.41%. I'd like to point out that Gifford Medical Center, along with its other affiliated organizations, is a member of a obligated borrowing group. So Gifford Medical Center is jointly and severally liable to meet all debt covenants of the corporation. A recurring theme is that Gifford Medical Center has budgeted for capital expenditures in FY25. We're budgeting $3.4 million for much needed capital improvements. Next slide. Other elements of our budget is our other operating revenue is budgeted to decrease from 24 to 25, partially because we're regrouping some school-based therapies up into net patient service revenue and not into other operating. We're also budgeting $0 for 340B due to pharmacy company restrictions. On a non-operating basis, we are budgeting for contributions from our community, because Gifford is fortunate to have the support of its community year over year. But one thing that we are not budgeting for is any investment gains or losses, as the stock market is unpredictable at best. And I too will be answering questions as we move through. Next slide, Steve. As mentioned, $3.4 million of annual depreciation. Our average age of plant currently is greater than 18 years, and the $3.4 million that we would like to spend on capital improvements is less than our annual depreciation. So our age of plant will increase even though we're able to spend this money. Things that we've deferred from 2022 is emergency room renovation. We need to do some roof replacements, some remodeling, and larger equipment purchases would be our anesthesia machines, a C-arm, an X-ray machine, and an echocardiograph machine. And with that, I will turn it back over to Dan.
Thank you, Bill. I want to just start before I go through the last slide here to thank the Green Mountain Care Board for your understanding last year, you did make a request to come out and meet here at Gifford first in the middle of 2023, and we asked you to please reconsider coming in the fall due to the work we were doing on our electronic health record. And then we moved our implementation to the fall, and once again, you worked with us and showed patience with us on that. So thank you for doing that. If you would like to reissue that invitation, we'd be glad to welcome you here down in Randolph and show you some of the things we're working on, including some of the things that you've heard today. But we'd be happy to host you for that. And we appreciate, again, your patience last year. So in closing, our Gifford team is focused on the right things. We're currently working to meet the needs of our community by investing in activities that will keep people healthy and avoid more costly services where possible. We are engaged in making our services sustainable and working with multiple partners in these endeavors. We're working to ensure that we have a talented, engaged workforce, despite forces beyond our control. And we believe that all who need our services should be able to access them. So once again, our 2025 budget supports these efforts, and I thank you for your consideration, and I'll turn it back to Chair Foster.
Thank you all very much. I'll open up to the other board members for any questions they may have.
Great. Thank you so much. Thank you, Mr. Bennett and your team, and welcome, Mr. King. This, I guess, is our last time together, Mr. Bennett, so I wish you well on your next chapter. My next chapter is coming soon, a couple more years, but so a couple of questions, actually a lot of questions, but I'll try to keep them concise. I want to understand the 8.2% NPR increase, and I'm wondering if, and this may be something that you can either walk us through now or submit separately, but I'm trying to understand the price effect separated from the utilization effect, separated from the revenue cycle EHR effect in particular. And I understand utilization is declining. The price is obviously to some, we know what the rate request is. I am trying to isolate the EHR revenue cycle effect in that 8.2%. Is that something you can speak to now, or is that something that we should just wait for further,
Bill,
submission?
is that something you, sorry. Bill, is that something you can speak to now, or do you want to follow up?
Yeah, I can speak to one high level item in the budget is with our new EMR and our outsourced partners, we've drastically reduced the amount of denials that the organization has seen. So from one year to the next, it's work that we were already doing, bills that we were already sending out to the payers, but they were denying them, and we didn't have the workforce to go through and rework those. So with our partners are able to surge at that. So they're able to cure those denials and generate additional net revenue for the facility.
Yeah, I think it'd be really helpful for us to identify of the 8.2%, what do you think is really just getting paid appropriately for existing work that you're doing, and what is the price effect? And then I understand there's a net negative utilization effect in there as well. So those moving parts would just be helpful to understand if you could.
We can follow up.
Follow up is great, I think, just to get the numbers there. You're requesting a 6.8% increase in rate. Can you just tell us how that's distributed between inpatient, outpatient, and professional?
Yep, I'll take that one again, Dan. So it's across the board. So it's a 6.8 for all areas.
Okay. Great. And so one of the areas, that we are trying to understand is relative pricing. So I think you've heard us talk about the RAND 5.0 the RAND 5.0 data, which is just one data source, but it does suggest that Gifford's standard price for outpatient is significantly higher than other, hospitals in the state. I think there's 10 or so hospitals that are cheaper on an outpatient standardized price basis. Inpatient, Gifford seems to be middle of the pack. Can you help us understand why the outpatient relative price is so high? And then how do we think about that when you're applying that 6.8% rate increase evenly across the three areas of inpatient, outpatient, professional?
Bill, do you have that one?
I don't have that off the top of my head, but I can follow up with a written response.
Okay, that would be fantastic. It seemed as though from the materials that were submitted, that part of the justification for the budget overall and the rate request that does exceed the board's guidance is the need to support some of the losses that are incurred across the other corporations under Gifford Healthcare. So, and this may require follow-up, but I would like to understand what were the losses for the FQHC in 23 and 24 projected, and what are projected losses in 25, and the same for the retirement community, just to understand how this rate might be used, or this revenue, as it said, I think in here, this is the primary revenue source is the hospital for the collective entity. It's really important for us to understand what the losses are in the other aspects of the corporation.
So the only direct subsidy is the federal government does require that with the federally qualified health center, that if it has a loss, that it can't have a loss. So any loss that's incorporated there, they want us to identify a source. So for us, the source is the hospital. I believe in the budget we are anticipating $800,000 and for that, it's not exactly 800, but it's 800 and change for that. We do not have any direct subsidy of the nursing home. The point that we were making in the narrative was that in terms of our debt covenants, we are jointly responsible for that. So within that structure, we do have to have enough of the bottom line for our debt service coverage ratio covenant, and then we also have to meet our days cash on hand covenant for that as well.
Okay, so what has been the impact of the combined losses on the days cash on hand for the past couple of years of those other entities? Is that something that you are able to compute for us or calculate, or in follow-up is fine?
Yeah, we can calculate that for you, but I'd love to follow up with it.
Okay. If the other two entities broke even in fiscal year 25, would or projected to break even, would your commercial rate request be different? Considering your debt covenants and your days cash on hand impact and the need for capital investment and all of that. I'm wondering if there's a way for you to back out for us what would be the commercial rate request if those other two aspects of the corporation were breaking even.
Yes.
Follow up?
Yes. I mean,
Okay.
Yes. So organization wide, our bottom line in this budget is 0. So yes. So the difference is, Bill or Steve, do you have right in front of you what the overall? We can answer
That's okay.
now,
I don't like to do math on the fly. So if you don't like to do
Okay.
math on the fly,
Okay.
and just to make sure that we're getting it accurate, it would be helpful for us to understand if the other two entities were literally breaking even, what would the commercial rate request be for this year for the medical, for the hospital?
Okay.
Specifically, it looks like you're budgeting for a near doubling of the fringe benefits for MDs. Whereas non-MD fringe is only up about 5%. The fringe benefits for MDs is up 93%. And I'm wondering if you can speak a bit to that. seemed like a little bit of an outlier there.
Steve,
Salaries.
is that something you
yeah.
can speak to?
Yes, it can. It is something I can speak to. So what we actually had happen during our budget process is a changing of how we were mapping salaries for our APPs into the same bucket as MDs. It's due to an accounting change in our own EMR system. It is very difficult to separate out those benefits and wages. So that is actually where the shift is you're seeing. And we did not increase benefits more for MDs than we did for any other grouping.
Okay. Fantastic. That's helpful to understand. And it looked like there was a 20% increase in consulting purchased services. Any thoughts on what that is?
Yeah, we outsource billing and coding.
Okay.
So that went from salaries and wages to contracts.
Okay. Okay. Inpatient, can we talk a little bit about inpatient care revenue? Just as I look at it over time, you know, in 2021, it was about $24 million. In 2022, 17 million, 23, 14 million. This year you had budgeted 17 million and it looks like it's coming in at about 9 million. So really precipitous decline there. I'm wondering, and next year it looks like you have it budgeted at this year's approximate projected amount. I'm wondering if you can speak to what's happening on the inpatient side in terms of this pretty significant drop in revenue.
Jill, do you want to speak to that? You're muted.
I'm sorry. So we didn't have a really strong formal utilization review program in prior years, to be honest. We have implemented the interqual system and really shored up our care management. So our length of stay has dropped and our patients' overall stay in the hospital has been less. So thus we're not getting charged for those, you know, we're not getting reimbursed for those additional days, but it's what's best for the patient. So significantly shortened our length of stay and the process of which we move them through the system.
Got it. Okay. And so what is your average daily census there now? Typically, say for 2024.
Right. So we have ranged anywhere from a high of 17 to 18 down to 4 or 5 and huge fluctuation. I mean, yesterday afternoon we were at 7 and this morning we were at 11 in our 12. So it just big variation, but they don't stay long. So you are doing a lot of work and turning a lot of patients over only to have the day end at 10 or 12. So we staff for a max of about 15, but we see around that 10 as our average.
Okay, so you staff for 15 and 10 is about the average.
Well, we can flex to 15. Yeah.
Okay.
Yeah.
Okay, got it. Your 340B revenue is budgeted for 0 for 25. What is the projected revenue for this year? If there was any.
We're not projecting any for this year. The vast majority of our 340B goes through our FQHC.
Okay. Has that
And
been the same as in the past? Is that a switch? It's always gone through the FQHC?
It's always predominantly gone through the FQHC since we've had the FQHC. It's been marginal at the hospital, but we have been impacted by the pharmaceutical companies, additional restrictions, particularly on the hospital side. So now it's marginal to nothing.
Okay. And then two other questions. Hopefully they're fast. On the non-op revenue, it looked like in 23, it was about $3 million. In 24 budget, it was budgeted at 0, but it looks like it's projected at 2.7 million. And then it looks like you're budgeting, if I'm right, 300K for this year. Is this all, and you talked about donations, this is all donations? Is this investment revenue in there as well?
I'm sorry, were you talking about other revenue or other operating revenue or non-operating?
Not
Non-op.
Okay, sorry,
non-operating.
go ahead, Bill.
Yeah, so the 300,000 that we're budgeting in non-operating this year is solely for contributions and fundraising. The
Okay.
$2.7 million that's in there for actual 2024 is investment gains and losses,
Okay.
which
And-
flow to that.
And then 23, the 3 million was largely investment gains and losses, some contributions.
Yes.
Okay. So for the last 2 years, you've been, for 23, you get 3 million, in 24, 2.7 million. So is it possible that the 25, obviously we don't know what's happening with the stock market, but is it possible that that's a conservative estimate of non-operating revenue for 25? The
Well,
300K.
it's, as you noted, it's completely dependent on the stock market. So,
Okay.
we typically don't budget for gains just because I can't remember the word Bill used for it, but the fickle nature of that. So,
Right.
if we depend on it and it's not there, then yeah.
Understood. Okay. And then my last actually is just more of a request on the clinical productivity front. Those percentiles are designed to cap at 100%. That's how the most productive practices in the country are at the 100th percentile. So the data that you submitted obviously exceeds the 100th percentile on a lot of different areas. So my guess my request would be in the follow-up to understand how you calculated those percentiles, and actually if you could just submit the benchmarking data that you used.
So Steve,
the underlying
Steve,
raw
sorry.
source of data there would be helpful.
So Steve resubmitted that last week.
Okay.
And the problem with the original data was we were using MGMA, old benchmark data for MGMA and using their more updated actual. So we had to go back and change it. So you now have the updated, which is comparing apples to apples, and nobody's over 100%.
Nobody's over 100%. Okay, sorry. With all the things that are coming in, it's
No,
hard to
understood.
keep track of all of the data that's
Understood.
coming
Yeah.
in. Okay, that's helpful. Back to you, Chair. I think those are all my questions. Thank you.
Oh, great. Thank you, Member Holmes. Any other board members?
I have a few remaining questions, although I must admit that Jess asked 85% of them or something. So it's going to take me a minute to sort through my questions because so many of them were asked.
From now on, I want to go after Member Holmes.
Yeah, I did have a little bit more. I just want to understand this decline in inpatient revenue a little bit more. At Copley's hearing the other day, we discussed a decline in inpatient revenue that occurred a couple years prior to yours, and it seemed like that may be associated with moving orthopedic care into an outpatient setting. Is that related to some of your inpatient revenue decline?
It is. As I noted, we have Dr. White raised his hand, so I guess I'll let him answer.
Yeah, that's the trend that you're seeing nationwide, and largely it's a standard of improvement in care. From the orthopedic perspective, 10 years ago, if you had a hip replacement, you spent a week inpatient on a PCA getting dilaudid. Now you go home same day with Tylenol. It's a market improvement for the service to the patient, but a significant loss as far as inpatient revenue. That same thing applies to a number of general surgery applications, gynecological applications, as there are laparoscopic advances, etc.
Okay. Yeah, I was curious if that could be related to that. I looked at maybe about a little over 40% decline. Does that impact your critical access hospital cost-based reimbursements adversely to not have the associated inpatient costs? Does that create challenges for you?
Steve, do you want to take a shot at that?
Yeah, so what you're referring to, the outpatient visits would still be counted towards that cost-based reimbursement. The only piece that gets what's the word, excluded from that reimbursement is the professional piece. So, and that would be the case on inpatient as well. It does change it a little bit, but based on the models we've run, we haven't seen a huge change in what we're expecting.
Okay. You mentioned that inflation you're experiencing is 2.8%, but your commercial rate request is 6.8%. Can you help me square those two?
Yeah, so we gathered our inflation rates with help from our group purchasing organization and applied those to our expenses. So that's why we're able to maintain a weighted average of 2.8%. But in order to meet our debt obligations, we had to raise up to 6.8% to end up at the right amount.
And those debt obligations are across Gifford Health, is what I think we were talking earlier.
All three entities, yes.
Okay. What is included in the Gifford shared services?
Steve, do you want to discuss that?
Yep, I can take that. So Gifford Shared Services are all of our overhead departments. So it'd actually be administration, accounting, patient financial services, medical records, so on and so forth. All the pieces that support the operations of all the corporations. And we actually allocate those to the medical center and the health center and retirement community through cost report approved allocation methods.
So I wanted to touch on the RAND stuff as well. I think Jess spoke about it and really framed some of my thoughts as well. But Gifford is one of the hospitals in Vermont that on the RAND data looks like it has very high standardized prices especially for outpatient services. And looking at the workbook, roughly maybe 10-to-1 outpatient to inpatient revenue ratio. It looks like maybe 85 to 90% of the revenue at Gifford comes from outpatient compared to inpatient. So that outpatient price really impacts your revenue, but it also really impacts clearly the price that people in your community are paying for healthcare services and and our overall healthcare spending. So I was trying to figure out, I was just hoping you guys could give me some thoughts about how you try to balance high prices for your community with hospital sustainability.
So first off, I'd just say we need to analyze that RAND data a little more closely. In particular, what year was that looking at? Because we did some reallocation based when we did our EMR. And I believe we did address some of these concerns that you're bringing forward and Board Member Holmes brought forward earlier. But we need to look at that so that we can answer it, correctly back to you. So, in terms of affordability, I mean, that's in part why we chose to talk about some of the things that we did here. Earlier, we are, we have long been a proponent of population health, of trying to help people where possible avoid more costly care and try to keep them healthy where we're able to do that. And so the items that we talked about earlier were designed to illustrate that. But in terms of the RAND study, again, I do believe that that's probably data that predates the changes in our electronic health record system and our charge master. So we would need to compare that back to, to where we are now.
Any insight to understanding this better would be helpful for us. I believe the RAND 5.0 data is from 20 to 22 and have up here, I mean, you had reasonable charge increases during that time, but I also remember from last year's budget hearing that you discussed that you had not been able to update the charge master for a couple of years, and it sounded like there was going to be, at least the way I came away from that, and please correct me if I'm wrong, is that that once that charge master was going to be updated, there would be an increase in prices that you weren't able to reflect your prior few budget rate increases. So I guess I was going to ask a question, but maybe should we expect a big increase in prices due to that updated charge master, or is there some other way you're approaching that?
So when we reworked the charge master in 2024, there were some areas that increased and some that decreased with the net impact, netting out. What we did last year, in terms of what the board approved, was reimbursement increase. There was a small rate increase, but large part of what you approved last year was reimbursement increase. So increasing what we're paid by the insurance companies as opposed to increasing our rates, that entire amount. So that was what we were unable to take advantage, or we were unable to enact in the prior couple of years, because we had identified that we needed to improve our revenue cycle in our charge master. So it wasn't what you improved wasn't simply a rate increase over that time. We negotiated our reimbursement from the insurance companies.
Okay, that's my understanding, is that when the board approves an increase, it's improved. It leads to an increase in those negotiated rates that are averaged over the services provided by a single insurer. I guess I'm still trying to help me understand the charge master impact of all this then.
So again, to get to specifics, we would have to, I can't answer all the specifics for you without going back and doing some research. But we had some areas that we brought charges down when we put our electronic health record in we had to create a new charge master for the new electronic health record. And there were some areas where we reduced charges because of the very reasons you're talking about. And there are other areas where we were lower that we leveled that out.
Okay.
But all in all, you should expect
a narrative
that
explanation would be helpful, I think, for us to understand it, because I must admit, it was challenging for me to quite understand how that was working last year too.
Okay, thank you.
So one thing that was a standout in the workbook, which I know there's some challenges with some of the data in there, but it appears that when we look at patient boarding in the boarding section of the workbook, that Gifford actually generates revenue off of patient boarding. The way I read it is that for the associated expenditures, they all had associated reimbursements that were higher than the expenditures, which I must admit, I don't know I need to sort of go look at other hospitals on this now. I mean, I definitely looked at many of the hospitals, and none of them showed that basically they were generating income off of patient boarding, but it appears, and I don't know if that's a function of a critical access hospital based on the cost-based reimbursement, but I was just wondering if you could sort of help me understand this a little better, why there could be, how it is that you can have higher reimbursements than your expenditures on patients that are boarding. This is inpatient boarding, awaiting discharge home or to a post-acute care.
Steve, do you have the answer to that?
Yeah, so and so a lot of the revenue and receipts is estimated because we don't have a direct correlation between those visits and reimbursement. And we get a settlement on the cost report for costs associated with visits. And it was just an allocation of those. Again, it was an estimate, and it could be, if we were somehow able to do a micro view of it, it might not be, a profit, might be a loss, might be break even. But not having that actual data to drill into is difficult to come up with a number.
Okay. Give me 1 second. And then the last question I had for you is, I was looking at your balance sheet and looking at cash and assets going from FY20 to FY20, FY24 budget. FY23 actuals have a pretty low total current asset number in here of $9.7 million, with cash and investments going from 17.9 million in 2020 to 1.3 2020 actuals. I was just wondering if you could help me understand this downward trend in your cash position. Yeah.
Steve, do you have that, or you?
Yeah, I think so. So during the pandemic, we actually received an advance from the payers to help float cash while we were working through the pandemic. That did go down through the years, which is why you saw a decrease. Also, budget 24, we were budgeting a higher utilization, which we didn't realize. We're also in an EMR implementation year, which also caused cash reserves to dive, as any other hospital going through an EMR implementation will experience. Does that answer your question?
I think
also have
I think that
loss.
does. Yeah. Okay. All right, that is what I have for questions. Thank you so much.
Any other board members?
I can jump in with, I have just a couple. Most of my questions also have been answered. This is really, I think, related to one of the follow-ups that Jess asked for, but I was noticing that when we look at 24 projected to 25 budget, the NPR increase is actually 13.2%. So when you're doing that breakdown related to the better collection issue, it might be helpful to, if some of that 13.2 is also driven by that, that would be helpful to know, because I think that's a big shift from where you're actually expecting to end this year to next year's budget. So I wanted to just ask about that and put that in the hopper. And then the other question I had is, why is it, given sort of the issues with the bond covenants, et cetera, why is this the year to catch up on capital expenses?
Because we've been deferring them for some time, and as you know, you can only defer them for a period of time. I wouldn't categorize 3.4 million as a big catch-up year. Or as Bill noted, it's less than our annual depreciation. So in fact, it is going to be, our age of plant will go up based on this plan. So I think our point in that was that we can't continue to defer to the extent that we have the last couple of years. But you know, I would not categorize it as a big catch-up year.
Thanks. And then my last question is, you noted that on the resubmission on Friday that you updated the productivity numbers. Could you also let me know what else you changed? Because quite frankly, getting that so late did not give me time to understand what changed between in the new submission.
So you want, in addition to,
was there anything else that was updated other than productivity?
Yes, I can answer that if you want, Dan.
Yeah, go ahead.
So the previous submission included APPs as well as physicians. It was a misreading of the requirements, so that also removed the APPs and just has the physicians as well as the 2024 MGMA numbers.
Thanks. Appreciate it. That's all I have.
Thank you. Member Walsh, do you have any questions?
No, Chair Foster, I'm all set.
Great. I just have one. In the narrative, you noted that Gifford budgeted 3.9 million of fixed prospective payments for fiscal year 24, but there's a reduction from the expiration of Medicaid's COVID-19 expansion, leaving a shortfall of 1.3 million. Did any of that reduction in Medicaid FPP show up elsewhere, as in commercial or people transitioning to another payer?
Bill or Steve, I mean, I can wage an answer, but
I can try to tackle this. So some patients more than likely did go to self-pay, some did go to commercial, but we don't have any direct correlation that we can provide. It would take some considerable drill in. Is that something you would like?
Well, so it's just not clear to me that it will actually be a shortfall if they end up as self-pay or in commercial.
so it's unlikely that significant numbers of them ended up in commercial. These are people who were no longer determined to be on the Medicaid rolls. So, this is something that every hospital that participated in the all-payer model was. We all had the same impact from this. I can talk a little bit about, and we do have, like Grace Cottage was talking about previously today, we do have a program called Health Connections, where we have now 2 counselors who meet with people to try to identify what benefits are available to them and or help them sign up on the marketplace for benefits. So we do work diligently toward that. But again, to Steve's point, we would have to track each individual member to know that. And it is possible that I'm sure some of them did either through the marketplace or other ways obtain other benefits. But our point in including that in the narrative was that was why that individual line item was so far off from what we had budgeted.
And what's your best supposition about where the bulk of these patients ended up? So if they're not on Medicaid, some small number ended up potentially in the QHP plans. Are the others just self-pay or not going to get care or are in free care or bad debt?
I would be guessing, but I mean, yeah, I would be guessing.
Fair enough. I don't have any other questions. I'll turn to the healthcare advocate.
Good afternoon. Thanks, everyone. Just a couple questions. I'm wondering, one thing that we look at obviously is free care to bad debt or bad debt to free care. I'll use the second one, bad debt to free care. One thing we observe is changes between what folks budget and what the actuals are. There's a lot of variance across the hospital system. And one thing I thought was particularly notable about your submission is that you're really projecting to go from 4-to-1 bad debt to free care to almost 1-to-1 in just 1 year. And I guess I'm kind of piggybacking on Sheriff Foster's question. How confident, I guess, are you that you can do that transition, which is a pretty big one, in just 1 year?
Bill, do you want to speak to that?
Yeah, so Act 119 went into effect on July 1st. And so I went to our counselors and asked them, how many new applications have we had since the 1 month? So for the first 6 months, we had 150 applications. And in the first month of it with Act 19, we had 70 new ones. So I am very confident that we're going to be able to move all of that into to that free care or free or discounted care. Also at our registration desks, when somebody comes in, we have a grid and ask them to please provide an estimate of where their household income and their family size is. And so we're capturing that in in our EMR system as well. And I think that just brings it to the forefront of everybody's thought that, oh, there is free care available. So anecdotally, I do see that Gifford will be moving towards that. And it really is, a great thing for the community as well.
No, thank you.
think
And thank you. Yeah, go ahead. Sorry.
No, I was just going to say that I mean, I'm going to say the same thing. One of the individuals in Grace Cottage said is that we still have a large number of people who will not provide the information so that we can move them into that free care category. So we will continue to work with that. As I noted, we do have now 2 counselors who do work with people, and that is something that we do diligently work on. As we would prefer that they, if they're eligible, that they do get that benefit.
No, thank you. Apologies for interrupting, and thanks for working with our office. I know that we've been in touch, helping you to come into compliance. I have 2 questions based on my review of your audited financials, and I'm wondering if you could elaborate on your contractual relationship with Mazars USA. It looks like around $1.5 million you paid them in 2024, and looks like you have an ongoing commitment with them for a couple years. Just wondering if that's still active and what services you get for them.
That's the group through which we did the outsourcing for billing and coding. So that is, we do have an ongoing contract with them for that.
Okay. And the other one is you talked about, I think just in the narrative actually, in talking about your performance and audited financials, you talked about the retirement community. And one of the plans that you had was reducing expenditures in the areas of supplies and purchase services. I'm wondering like how big of a problem you think that is in terms of kind of mitigating some of the ongoing losses there.
That alone isn't going to get us there. That is an initiative we have. What we've identified in particular is that there's improvement we could make in the cost of raw food. That is a big part of it. Although, as we all know, food costs have gone up significantly. So trying to find ways to be more efficient in what we're doing there. We're also looking at expense lines across the board. I will. We are working with the Agency of Human Services as well. We did make an application in their Extraordinary Financial Relief Program for the nursing home specifically. It's for nursing homes, and we are in the final stages of that. And we're just waiting for the final paperwork from them to sign that EFR agreement. So we will get some temporary relief from that specific to the nursing home.
Okay, thank you. The last question, I was just curious if you could speak a little bit more about the international recruitment. That sounded really encouraging. And I'm wondering what were some of the biggest challenges and barriers to getting that started?
That's Jill.
Yeah. So our whole immigration system. So if you guys could fix that, that'd be awesome. So I have found it's most successful with nurses that have come here and are American educated and already have their student visa. And then it's really a process of converting that student visa to a work visa. And you have to have that sponsoring organization. InSpring is a company that we've been using to work with them, and they you pay them a fee, but they have immigration lawyers who really can hone in on what needs to happen and can really kind of simplify a very, very complicated process. It's a couple barriers that we have is that in order for this workforce to come in, it has to be in positions that are designated for higher level degrees. So they have to be positions that require BSN or MSN jobs. So like in our lab area, we can't bring them in if you could have an associate doing the job, an associate's degree doing the job. Or in areas like in our med surg floor where we don't require everyone is BSN prepared, we might prefer it. We can't bring those folks in. So there's some barriers that are built within the system. The nurses that are practicing nurses in other countries, that are trying to come here without having that student visa. It's a little more challenging for them. They have to, it's about $5,500 for their spouse and any of their children to come over. We certainly pay for them to come over, but a family of 4 is going to have like 20 grand just to try to come into the country. And then their spouse will not have the ability to work here because they won't have a social security number. So only one of the working household would be able to work. So it's a lot of this is really within our immigration system. But I can honestly tell you that the nurse that we brought in is fabulous. She's thankful. She's a hard worker. She's great. She's, you know, we're just so lucky to have her. And we have got a couple others in the queue. And I was planning for them to start at Dartmouth on the 19th of August with their Peri-Op 101, and they haven't made it through processing yet. So, some big opportunity there for sure. Because we, you know, even if everyone's doing everything right and we're trying to shore up our schools of nursing, we don't have enough folks to fill how many people are leaving the profession. So we do need to look at external sources. You've got great qualified people that are more than willing to come here and want to work here. And so I've been happy to work with that company, and I would like to use them for more things, but have a lot of limitations on that. Did that answer your question?
Yes, no, thank you. I appreciate it. I mean, there's a lot of activity in the J1 waiver space legislatively too. So, but yeah, no, thank you. I appreciate it. And those are all my
Okay.
questions.
Sure.
Chair Foster, is your audio struggling right now? I think it might be. So with that, I think what I will do is I will thank you all. Gifford, we really appreciate all your time. I don't think there's any other, unless there's public comment. I think public comment will be at the end. So I think what we will do is pause and come back at 3 o'clock when we will hear from North Country. But thank you again to the Gifford team for your presentation. Really appreciate it.
Thank you very much.
Thank you.
Thank you.